from Sarasota Memorial and the Deb Kavanaugh Multimedia Studio, this is HealthCast, a healthy dose of information from experts you can trust.
Hi, everybody. Welcome to HealthCast. I'm Allison Gottermeyer. Thank you so much for joining us today as we talk about comprehensive care for prostate cancer. Our guest today is Dr. Kunal Sehgal, Medical Director of Radiation Oncology for the Brian D. Jellison Cancer Institute here at Sarasota Memorial. Dr. Sehgal, thank you so much for joining us.
Thank you for having me.
Prostate cancer screening has been a topic of debate for years. Can you just briefly walk us through why it's so controversial?
Yeah, I think that's really the beginning of this whole conversation. There's a great deal of controversy over prostate cancer screening that really goes back for the last 20 to 30 years. And most of that really comes from the fact that the management of prostate cancer is challenging because the vast majority of men who are going to be diagnosed are in the later stages of their life. And while prostate cancers are, for the vast majority, very curable, many men may not truly ever derive the benefit of that treatment if they're not living long enough after treatment to really have truly had their overall lifespan or natural history of their life altered by the treatment. And so what was happening for many years is we were probably to some extent over-screening men who maybe didn't have an adequate life expectancy ahead of them, and then finding relatively indolent or slow-growing prostate cancers. Patients then were undergoing treatments that in some ways were felt to be unnecessary because all treatments have potential for side effects. And if that patient was only going to live another 3 or 5 years, it is quite unlikely that the prostate cancer would have any meaningful impact on their overall outcome. Now, where that gets challenging is if you don't screen men, you have people who sort of escape and end up being diagnosed with advanced disease, which requires very complex treatment, or in some cases, even metastatic disease, as we saw recently, that had a lot of media attention around our former president being diagnosed with metastatic prostate cancer, which was a huge shock to, I think, our whole country that could happen to a sitting president or recently sitting president. So I think the right idea is that there needs to be a happy medium. I think that patients need to sit down with a urologist if they have one, or with their primary care physician. Look at them from a holistic approach. Look at their comorbidities. Do they have really poorly uncontrolled heart disease and diabetes and kidney failure? Maybe that patient doesn't benefit from prostate cancer screening. But we have other patients that are 75, 80, sometimes 85 here in Sarasota that are extremely healthy, live extremely vibrant lives, and really may live for another 10, if not more years. And those patients probably are very appropriate for prostate cancer screening.
So how are you seeing physicians approaching those conversations with their patients around whether they should or shouldn't have that PSA testing, especially if they're completely asymptomatic?
So the first thing I would mention is the vast majority of prostate cancer patients will be asymptomatic.
Okay.
The anatomic location of where the cancers occur is usually on the posterior or back side of the prostate, closer to the rectum, far away from the urethra. So many men have what we call benign prostatic hypertrophy, so they're having more urinary changes, more frequency. Those are usually not cancers. That's a benign process that happens with aging due to chronic testosterone exposure. So screening is essential because if without screening, we will likely only diagnose prostate cancer patients that have extremely advanced disease. I think that since the guidelines have sort of shifted, I think the pendulum has swung a little bit back to the middle. I think we went from an extreme of screening everybody with a PSA every single year to not screening anybody. And now we're sort of getting back to a happy medium. And I think what I'm seeing as an oncologist is that patients are having much more appropriate discussions with their primary care physicians. And I think there's been better education of primary care physicians in terms of in whom the screening is truly valuable versus not. So I think it's really kind of finding that Goldilocks of when it's just right. Maybe everyone doesn't need a PSA every year, but every other year, and just monitoring the trend. And then there's other factors as well. We know that, family history is important. Other metabolic syndromes, obesity, diabetes, all of these things create an inflammatory milieu inside the body. And those patients are unfortunately also at higher risk for cancer, not just prostate cancer, but unfortunately cancer across the board. So those are some of the patients that could benefit from screening as long as they have a reasonable life expectancy.
So the patients that you're seeing as an oncologist have already gone through this and have been diagnosed. Once a man is diagnosed with prostate cancer, what are the main factors guiding the choice between surgery versus radiation?
Yeah, so there's a number of factors. I think age being the most important. Obviously, younger patients are probably more suitable for surgical management than older patients. How advanced the disease is. I think for organ confined disease, and I think the other thing that's worth mentioning here is MRI. In the last 10 to 15 years, I think MRIs have really become standard, even before biopsy, as your PSA is rising, to get an MRI of the prostate. It's sort of like a mammogram of the prostate. We can really see a great deal of soft tissue anatomy inside the prostate and get a much better and clearer picture as to what's going on than what the older technique was, which was rectal exam. I think that also has led to less screening because patients and don't enjoy having rectal exams. So I think the MRI has created a less invasive and more sensitive and specific approach to screening patients. So getting back to your question about treatment, though, if you have organ confined disease, those are really the patients that I think have a good choice between radiation therapy and surgery. As the disease becomes more advanced, if there's lymph nodes involved, or if we see the tumor clearly extending beyond the prostate, then that patient is unfortunately likely to not be cured by surgery. So in that case, it is likely going to be a multimodality approach with radiation therapy and sometimes also with hormonal therapy, which is essentially blocking testosterone, which is the fuel for most prostate cancers. So it's a number of factors. You really have to look at the whole holistic approach again of the patient. What is their age? How healthy are they? What is their urinary function like? If they have good urinary function, they're a better candidate for radiation. Some patients have very, very poor urinary function because they have a very large prostate. And those patients sometimes are better candidates for surgery because you're able to manage not only their cancer, but some of their chronic urinary obstructive symptoms at the same time. So it's a little bit of a 2-for-1.
Are there pros and cons of radiation therapy in comparison to prostatectomy?
Absolutely. So, with surgery, there's basically two potential side effects. Urinary incontinence, which most men will have for some period of time after surgery. With that being said, the vast majority regain continence and are mostly or completely continent. The other, of course, is erectile function. While robotic surgery has significantly improved the ability to spare the erectile function by sparing the nerves, which are on the lateral edges of the prostate, it's still not perfect. With radiation therapy, the side effects are a little different. It's more kind of what we call urinary bother symptoms, so more frequency, more urgency, slowing of the urinary stream, possibly looser stools to diarrhea during treatment. Erectile function can also be affected by radiation therapy, though if you look carefully at the data, it seems like the preservation rates with radiation therapy seem to be slightly better than with surgery. And then, of course, patient preference. There are patients that feel strongly about having a cancer removed from their body, and those patients are probably more suitable for surgery. There are other patients that prefer organ preservation, and that's what radiation therapy provides all throughout the body, is we try to treat the cancer while preserving normal organ function as much as we can. So I think it's just really, it's a careful discussion between the various physicians and the patient, and taking into account really what the patient is trying to achieve.
Can you talk a little bit, that leads right into this question, about the collaboration at the Brian D. Jellison Cancer Institute with radiation team, with urologists, and everyone working to help patients make the most informed and best decisions for them?
Yeah, I think our urologists do an excellent job of sending essentially every new prostate cancer diagnosis patient to talk about radiation therapy as well as surgery. And so that way the patient is getting sort of that, specialized discussion with each individual specialist rather than one person sort of trying to quarterback the whole thing and sort of having to step outside their comfort zone. We also have a multidisciplinary tumor board that meets every other week. And so for the more complex cases, or if there's a concern about something on a patient's imaging that we want further clarification of, or if we need to consider another biopsy or something more kind of outside of the norm, we have that ability as well. And in the tumor board, we have all of the specialists together with pathology and radiology, as well as the radiation oncologists and surgeons, really discussing the case top to bottom again and rendering another opinion from that perspective. So I think if you are a new patient, it's very important that you are being offered that multidisciplinary approach.
Absolutely. Radiation therapy has come a long way in recent decades. What are the most exciting advances that you're seeing?
Yeah, I think the most exciting advances are really around technology and imaging. So as I mentioned earlier, MRI has completely revolutionized how we manage prostate cancer from pre-diagnosis through treatment because we have such a better view of really what is happening inside the prostate gland. So that's number one. And then with radiation therapy, we also have better onboard imaging, meaning imaging on our treatment machines. And what that allows us to do is actually visualize the prostate in 3 dimensions every single day prior to treatment. Thereby, we can reduce the margins, the safety margins, which we used to have to use in radiation therapy were large. They were up to 1 inch around the organ of interest. And so that created a lot of side effects. Today, our margins are often 2 to 5 millimeters around the target. And that thereby reduces the potential normal tissue side effects significantly. What that's also allowed us to do is deliver the treatment in a much shorter schedule. So prostate cancer radiation used to be 8 to 9 weeks. Today, for most patients, it's about 5 weeks. And for some patients who have kind of favorable disease, really good urinary function, good, favorable anatomy, they can have their treatment in just 5 sessions through a technique called stereotactic body radiation therapy, or SBRT. We also offer placement of a rectal spacer gel, which goes between the prostate and the rectum and helps shield the rectum from high-dose radiation exposure, because that has been one of the long-standing side effects of radiation therapy is potential rectal symptoms, whether that be rectal frequency urgency and in some cases even rectal bleeding. So that's something that we do offer here and is offered around the country to help reduce the risk for long-term rectal side effects from radiation therapy.
Can you explain what Pluvicto is and how it works for patients with advanced prostate cancer?
So Pluvicto is another new exciting modality that we also offer here at Brian D. Jellison Cancer Institute. It is different. It is for patients who unfortunately have advanced prostate cancer, metastatic prostate cancer, who have failed at least 1 to 2 lines of androgen deprivation therapy, which is that anti-testosterone therapy. Previously, Pluvicto was only approved for patients who have already received chemotherapy, but we now have a newer FDA indication, which is allowing it to kind of come earlier in the treatment course, and that seems to show much better responses as well as tolerability for patients. So what Pluvicto does, it is actually what we call a radiopharmaceutical. So we actually inject a radioactive isotope into the body through the veins, but that isotope only tracks to areas that express a protein called PSMA, or prostate-specific membrane antigen, similar to PSA, kind of like a cousin of PSA. And what this radioligand, what the PSMA does, it basically takes that radioligand only to those sites that express the PSMA. So if you have a patient with bone metastases and lymph node metastases and liver metastases, it basically takes that radioactive source only to those areas that express the PSMA protein, and then it delivers a very high potent dose of radiation specifically to those targets. The rest of it basically gets excreted by the kidneys over several days to weeks.
How does Pluvicto fit into overall treatment landscape? I know you mentioned it's for people with more advanced, but is this a first line? Is this a last resort? Is it somewhere in between?
So as I said, it does come only when patients already have metastatic disease. It is not yet approved in sort of de novo disease, which has never been treated before. But what has changed is previously patients had to have basically exhausted all of their standard of care systemic therapy options, including chemotherapy, which some prostate cancer patients who are elderly aren't really adequate chemotherapy candidates. So thereby they were never being able to receive Pluvicto either. Now, because it is approved prior to chemotherapy, that seems to be a much, it makes it more available to more patients. Anecdotally, I will say that I have seen some patients who had gone outside of the country and received Pluvicto earlier prior to chemotherapy, and we saw some really favorable responses. So we're hopeful that this earlier access is really going to drive improved prognoses for patients.
That is something we didn't touch on yet so much, is how many patients who are getting radiation also require chemotherapy or some combination of surgical and radiation. What does that look like?
Yeah, very good question. And this kind of goes back to that discussion about screening. So what are the advantages of screening? The advantage of screening is that you find the cancer early when the patient has the simplest treatment options, whether that be surgery or radiation therapy alone. Like I said, some patients with favorable disease can have just 5 treatments and have a 95+% cure rate in such a short treatment course with minimal toxicity. But unfortunately, as the cancers become more advanced, as the Gleason scores become higher, that suggests a more aggressive biology, or if the cancer has spread beyond the prostate, now we really need to tackle that patient with sort of a multi-pronged approach. And often that is radiation therapy combined with longer-term hormonal therapy. And that, unfortunately, the hormonal therapy has significant side effects of fatigue, muscle loss, weight gain, loss of libido, sometimes even cognitive changes, and in some series, even some risk for cardiovascular toxicity. So by diagnosing patients earlier, we have the ability to try to avoid some of these side effects that can actually really significantly impact their overall lifespan, because many of our patients as they get elderly are already dealing with some of these metabolic issues, which then are further exacerbated by the hormonal therapy. So it sort of leads to this downward spiral that we really want to avoid. So I think that the earlier we can detect patients, the better options we have to treat them with fewer side effects. But unfortunately, for more aggressive disease, it does require sort of a multi-spoke approach. Sometimes we will offer patients surgery, knowing that they may still need radiation therapy afterwards, and that's okay, because that has been shown to lead to favorable outcomes for the appropriately selected patient. I think patient selection ultimately is, I would say, sort of the underlying theme of this whole discussion.
And that's where it's so important to have that multidisciplinary team. Absolutely. Beyond the medical treatments, how important are lifestyle choices in this? Diet, exercise, stress management for patients going through prostate cancer treatment?
I think it's critical. So I think lifestyle changes are something that I think more and more, I think our population here in the United States is becoming aware of. I think we now realize that our diets, which are unfortunately high in processed foods, high in preservatives, high in red meats, and our sedentary lifestyle, those two things in combination really are not a good combination for cancer all across the board. And if you look at prostate cancer statistics worldwide, it is more common in the Western world, probably driven by some of these lifestyle factors that I just mentioned. There's very good data that shows that activity level, exercise, eating a wider range of foods, whole foods, sort of eating the rainbow, improves outcomes all across the board in cancer patients, not just during treatment, but even after treatment. And in some cases, to the same tune of some of the adjuvant treatments that we offer them after surgery and radiation, for example, in breast cancer, there's data that lifestyle choices are just as impactful as the hormonal therapy patients take for 5 years. So that's something I'm a huge proponent of. Sarasota Memorial Hospital also offers a comprehensive cancer survivorship program called Thrive that really focuses on trying to modify patients' lifestyles after they've completed their active cancer care to try and help reduce the risk for another cancer or recurrence of the same cancer.
Yeah. And what advice do you give patients about nutrition during radiation therapy? Because sometimes appetites change, things like that during treatment for any cancer.
Yeah, so there are some nuances to this discussion during radiation. As I mentioned, one of the things that can happen during radiation is more frequent bowel movements, sometimes even looser stools. So during the treatment, we do have to modify things and sometimes reduce fiber intake and some of those healthy foods for just that short period of time. But bigger picture, we really focus on that holistic approach, eating more whole foods. There's also data in prostate cancer specifically about eating more antioxidant-rich foods, tomatoes, pomegranates, berries that have something called polyphenols, which significantly can improve outcomes and even slow down cancer progression, like that cell cycle progression in cancer cells. So there's some nuances during the treatment and we have a lot of educational materials available for our patients. But by and large, we really support a healthy diet and lifestyle.
What do you wish more men knew about prostate cancer?
So some of the things that we talked about, some of the advantages to screening, I think that it just sort of has been met with a lot of resistance in the last 20 years or so. But I think what gets lost there is that, there are patients who unfortunately will die of metastatic disease because they were never screened appropriately. So I think trying to understand the benefits of screening is really important. Again, it's not, well, while it may not be for everybody, I think for the right patient it is. And I think I really try to stress the benefits of healthy lifestyle to my patients. That's something I'm really passionate about. One of the other things I want to mention about that is that we mentioned with hormone therapy, a lot of patients have muscle loss, weight gain. Well, how can you combat that? It's exercise, and not just cardiovascular exercise, but resistance training to avoid that muscle loss, or what we call sarcopenia. There's a lot of emerging evidence that shows that you really start aging when you start losing your muscle. And so we try our best to convince patients to really get serious about trying to maintain their health and their muscle mass, because that's what's going to keep them young long term.
Absolutely. If someone is listening or watching this and just got a prostate cancer diagnosis, or they maybe know someone who just got a prostate cancer diagnosis, what's the first thing you want them to know?
I think the most important thing is that the vast majority of men have highly curable prostate cancers, and most will never die of prostate cancer. I think that's the most important thing to know. And then number two, like I said, is to have a good multidisciplinary discussion with a team that you feel comfortable with to help guide you through the treatment, because it's complex. Even in our practice, we use a number of tools. We order a lot of tests. We order genomic tests on the tumor, and now we're using AI tools as well to try to understand, how aggressive is this cancer, so that we can then tailor how aggressive do we need to be. And sometimes the answer is that this doesn't seem aggressive at all. We'll just keep an eye on it. And so I think just making sure that you as a patient are very comfortable. You've done your own research, because there's a lot of information out there, and then you trust the team that's helping you kind of guide through all of that information, because there's a lot out there. And so our discussions are complex. Our initial consultations are typically about an hour. There's a lot to talk about. And I think as a patient, know that we're here for you to help spend that time with you to make sure that you understand what the options are and how to kind of navigate through this complex process.
Absolutely. I know we've talked about a lot of things, but is there anything else you want to add before we wrap up?
I would just say that, I'm very proud of the program that we built since I've been here for the past 5 years. I think we offer a really comprehensive approach, specifically with radiation therapy for prostate cancer patients. One of the goals that I was tasked with when I came here was to sort of be able to offer the full sort of, gamut of treatment for prostate cancer patients, so that they don't feel like they have to leave this area. And I feel like we're there now. And I feel proud to say that we've gotten there in a short few years. And we're excited to offer that to even more patients as we open, the cancer pavilion here at the main campus to kind of improve our patient access.
Yes, the Millman Cover Cancer Pavilion is set to open in early 2026 at the Sarasota campus. So, Dr. Sehgal, thank you so much.
You're welcome.
If you liked this episode of HealthCasts, please like and comment, and visit smh.com/podcast to listen to more experts like Dr. Sehgal talking about the health issues which matter most to you. As always, we encourage everyone in our community to visit smh.com to get the latest from Sarasota Memorial. Have a great day.